Welcome, and thank you for viewing this program. This module discusses the surgical procedure called radical prostatectomy. To review, the prostate is a chestnut-sized gland situated in the pelvis at the bottom of the urinary bladder, the place where urine is stored. It sits next to the rectum and surrounds a portion of the urethra, the tube that carries urine from the bladder out through the penis. The prostate gland secretes a thin, milky fluid which makes up part of the semen that nourishes and helps activate sperm cells. This slide shows how the prostate is associated with the male ejaculatory system. Sperm is made in the testicles and travels through the vas deferens to join the ejaculatory duct. Fluid from the seminal vesicles and prostate also passes into the ejaculatory ducts to bathe the sperm and create semen, which is expressed out through the urethra during orgasm or climax. Radical prostatectomy involves the complete surgical removal of the prostate along with its surrounding structures. It is indicated for localized tumors confined to the prostate in an attempt to cure the cancer, and for advanced tumors that have spread beyond the prostate to control cancer growth and improve survival time. This is often in combination with other treatments. This slide shows how the prostate, the seminal vesicles, and the ejaculatory ducts are removed, and the neck of the bladder is then sewn back to the cut end of the urine channel or urethra. There are three methods of performing radical prostatectomy. Radical retropubic prostatectomy involves an open operation through a small incision in the lower abdomen. A radical perineal prostatectomy is an open operation through a small incision in the perineum, the space between the scrotum and anus. Finally, a laparoscopic radical prostatectomy is similar to a radical retropubic prostatectomy, but is done using a video telescope and small instruments passed into the body with or without the assistance of robotic technology. In a radical retropubic prostatectomy, the surgeon accesses the prostate in the so-called retropubic space behind the pubic bone. This operation has been well refined and proven over many years on thousands and thousands of patients. With this vast experience, outcomes are well defined with excellent cure rates and low complication rates. Prior to coming to surgery, you will meet with your urologist, who is a surgeon specializing in the kidneys and genitourinary tracts. A medical interview will be carried out, and your medications and allergies will be reviewed. A physical examination, including rectal exam, is performed. Then testing may be ordered to further assess the prostate cancer. This testing may include blood and urine tests and imaging such as X-rays, CT scan, or bone scan. MRI is also being used more commonly to image the prostate. These findings are then reviewed, and treatment options, including surgery, are discussed. If you have any concerns, they should be reviewed at this time. Be sure your doctor is aware of all of your pertinent medical information, especially the medications you are taking, including over-the-counter medications and supplements, etc. Some medications and supplements can increase the risk of bleeding during surgery and must be stopped beforehand. Ask about your medications, including what you should continue taking up to the time of surgery. Following this review, you will be asked to sign informed consent for surgery. This is a very important document which indicates that you understand why surgery must be performed, other treatment options, what surgery entails, and what the potential risks are. The consent also allows your doctor to perform any other procedures that are deemed necessary to save your life, and to use the assistance of other medical personnel such as other doctors, nurses, and students. The consent also normally includes a note that allows your doctors to use blood and blood products if deemed necessary to save your life. If you have an objection to this, you must notify your doctor and have this section adjusted accordingly. Finally, some centers may ask for consent to use and study tissues collected at the time of surgery for research purposes. Prior to surgery, you will meet with an internist and/or an anesthesiologist to precisely determine your fitness for surgery. Through an interview, examination, blood tests, a cardiogram, and possibly other special tests, these doctors can rate your degree of surgical risk using a variety of scoring systems, such as the American Society of Anesthesiology or ASA scoring system. There are no clear-cut rules on when surgery should be performed. Recent reports suggest that it can proceed any time after biopsy. If you have undergone a transurethral resection of the prostate, or TURP, your surgeon may prefer to wait longer before further surgery. Beyond this, recommendations are difficult. Some men can probably safely wait many months, while others should not. It is best to proceed as soon as practically possible once the decision for treatment is made. Once this is done, it is time to prepare for surgery. In the days leading up to the operation, focus on living as healthy as you can, eating a balanced diet, and getting some regular exercise. Gathering the support of friends and family around you, as well as other patients who have had the operation, when possible, can help ease your mind and comfort you. Try to take other measures to reduce stress as well. Arrange time off work well ahead of time, and organize some help with household and other tasks before and after surgery. Learning about your condition and your surgery, through programs like this, can also help to relieve anxiety by removing the mystery of what is happening to you. Finally, it is important to understand and come to terms with the expectations of surgery as well as the potential outcomes. In preparing for surgery, some doctors will also recommend that you begin to do pelvic floor muscle exercises, also called Kegel exercises, which are a type of pelvic muscle training. These exercises may speed the recovery of urinary control after surgery. It is generally recommended that you begin these before surgery and continue them after catheter removal until full urinary control is achieved. A separate module is available that describes in detail how to perform these exercises. Many centers will utilize a special outpatient clinic called a pre-admission clinic. This may go by different names at different sites. At this visit, you will likely see an internal medicine doctor or internist and an anesthesiologist who will perform a medical interview and a physical examination. Lab work and special testing, such as an electrocardiogram or other heart testing, may be ordered, and your specific risk for surgery will be determined. You will be advised further about how to prepare for surgery, including which medications to continue. The night before the operation, eat a light meal, then take nothing by mouth for several hours before surgery. A common instruction is to take nothing by mouth after midnight on the night before the operation. However, individual instructions will vary. You may be advised to perform a bowel prep the day before surgery, such as drinking a special fluid to clean out your bowels. Try to get a good night's sleep, as it helps to go into surgery well rested. Finally, as individual situations will differ, follow the advice of your doctor or hospital regarding specific preoperative preparation. On the day of surgery, have someone drive you to the hospital and try to arrive early. You will likely first go to the admitting department and have some paperwork done to check you into the hospital. You will then be checked into the surgical area, where you will change into a special hospital gown and meet with a nurse. The nurse will review your medical history and check your vital signs, including your blood pressure, pulse, and temperature. An intravenous or IV line will likely be started, through which you will receive fluids and later medications. An enema is given in some centers where the bowel prep is not taken the day before. At some point during this process, you will meet with an anesthesiologist who will administer the anesthetic drugs and monitor your vital functions during surgery. The anesthesiologist will review different anesthetic options with you and discuss their merits and potential risks. Part of the anesthetic regimen used during a radical prostatectomy for some patients is a spinal anesthetic, which allows the doctor to give drugs directly into the spinal cord and nerve roots to provide excellent and focused pain relief. Finally, prior to surgery, you will meet once more with your surgeon, and any final concerns can be addressed. Once in the operating room, an intravenous or IV line will be started if not done already. As mentioned, a spinal anesthetic may also be given. You will then be put to sleep by the anesthesiologist, and a breathing tube will be introduced. Other tubes and monitoring lines may then be placed, including a catheter into your bladder to monitor urine output, and rarely an arterial line in your wrist to monitor blood pressure. Other monitoring devices are also used to check your blood level of oxygen, your temperature, and your level of anesthesia, among other things. The doctors and nurses will then carefully position you on the operating table in such a way as to optimize the ability of the surgeon to carry out the operation. For a radical retropubic prostatectomy, you will typically be placed flat on your back, possibly with a slight bit of flexion in the back, depending on surgeon preference. Once positioned, the skin is cleaned with special antibacterial solution, and an incision or cut is made. This incision is made starting from the pubic bone and extending toward the belly button for a distance of 4 to 8 inches, depending on the size of the individual. Once the surgical space is accessed, there are 4 main steps of the operation that may follow: lymph node dissection, nerve sparing in select men where it would be appropriate and not jeopardize cancer control, removal of the prostate, and reconnecting the bladder to the urethra. The pelvic lymph nodes are the usual first site of drainage if cancer spreads beyond the prostate. Removing these provides information on the extent of cancer and can help to control it. It is important to understand that a formal lymph node dissection is not required in all cases, and individual situations and surgeon preference may vary. Lymph node dissection is performed routinely in the following situations: a Gleason score of 8 to 10, or high stage cancer, usually higher than stage T2B, or a high PSA, usually greater than 10, or finally, when the lymph nodes feel suspicious in the operating room. The node dissection may not be done if the Gleason score is 6 or lower, and the stage is low, and the PSA is also low. In the operating room, if the lymph nodes feel cancerous, or in high-risk situations, the surgeon may send the nodes for a so-called frozen section. This is an examination done by a pathologist which provides quick information about the extent of cancer. If the lymph nodes are heavy with cancer, some surgeons may choose not to proceed further with prostatectomy. This is not a clear-cut issue, however, and should be discussed ahead of time with your surgeon. Once the lymph node dissection is done, removal of the prostate begins, and in the early part of this, nerve sparing may be performed. In this process, the penile or cavernous nerves can be released from the prostate and spared from injury to preserve erections. Depending on the situation, one or both sides may be spared. This step can improve the chances of recovering good erections after surgery. However, it does not guarantee recovery of erections, as there are many other factors that come into play which are discussed later. It is important to understand that not all men are candidates for nerve sparing, and your surgeon will discuss your situation with you. So when can these nerves be spared? While there are some guidelines, ultimately it is the surgeon's decision, and the final decision may not be made until the prostate can be felt in the operating room. The surgeon's first priority is cancer control, and this cannot be compromised for the sake of nerve preservation. General guidelines for nerve sparing are listed here. Firstly, the stage of the disease must be low, and there must not be a tumor nodule near the nerve. If tumor can be felt near the nerve, especially at the so-called apex of the prostate, then the surgeon will not spare that nerve. Secondly, the PSA should also be low. And finally, of course, the patient should already have good erections and a need to preserve his erectile function. Following nerve sparing, the prostate is completely disconnected from the urethra and bladder and carefully lifted away from the rectum. The vas deferens are cut, and the seminal vesicles are then removed. After sending off the prostate for analysis, the opening to the bladder, called the bladder neck, must then be sewn back onto the urethra to recreate the urinary tract. This is done over a catheter, which keeps an open channel for urine drainage while things are healing. Once the technical part of the operation is completed, a drain tube is then placed, which is separate from the catheter and serves to drain blood or urine from the surgical area. The incision is then closed, using strong dissolvable sutures on the inside and staples or stitches in the skin. A dressing is applied to cover the incision. Once stable, the patient is transferred to the recovery area for further monitoring and eventually to a regular ward bed. Initially after surgery, you will take only ice chips or water by mouth, but as long as you are not nauseated, your diet will be increased quickly. If all is well, you will also be encouraged to get up and move around soon after surgery. Until you are moving well, you will have special compression devices on your legs to prevent blood clots from developing. A catheter will drain urine from your bladder into a bag to monitor your fluid output. Pain control can be managed through your intravenous line, then gradually switch to pills. Over the first few days after surgery, you will learn about how to care for your catheter. The drain will eventually be removed, as will the staples in the skin, although these may come out after discharge. You will be discharged home when your vital signs are stable, your bowels are working, you no longer require an IV line, and you are moving well and comfortable with pills for pain control. Once you go home, keep physical exertion to a minimum in the first couple weeks, and take care to get plenty of rest, eat a healthy diet, and keep stress to a minimum. Continue your Kegel or pelvic floor exercises if your doctor has asked you to do these once your catheter is out. Gradually return to full activities by 4 to 8 weeks. Understand that it may take some time to feel that you are back to normal again. You may not be able to focus and concentrate as sharply as normal, and your physical energy and stamina may be diminished for several weeks. A urinary catheter is a tube that drains urine from the bladder to a bag outside. This tube is extremely important to allow the connection between the bladder and urethra, called the anastomosis, to heal without urine leakage at the site. There are 2 types of drainage bags for the catheter. You will likely wear a small bag strapped to your leg in the day, and a larger bag at the side of the bed at night. Catheter care is discussed in detail in a separate module. Follow-up visits will depend on your situation and the preference of your surgeon. Your catheter will need to be removed 1 to 3 weeks after surgery, again according to the surgeon's preference and also the technical issues which may have arisen during your particular operation. Some patients will be taught to take out their own catheter, while others will follow up with their doctor or nurse to have this done. At this visit, your doctor will check the healing of your incision and will discuss the pathology report with you. This is the report issued by the doctor in the lab, a pathologist, who inspects the prostate specimen and examines it under a microscope. If necessary, further treatment will be organized and plans will be made for regular follow-up visits. Some patients are concerned about catheter removal. Rest assured, this process is very simple and painless. To remove a urinary catheter, water is removed from the balloon valve with a syringe. This deflates the balloon that holds the catheter in the bladder. A steady, gentle pull will remove the catheter, which may feel a bit unnatural but will not hurt. You should have protective pads ready, as it is common to leak urine initially when the catheter comes out. Most prostate cancer patients undergo a regimen of regular follow-up examinations after surgery, including periodic assessment by a physician and PSA blood tests. The exact schedule of follow-up visits will depend on your specific clinical situation as well as the preference of your doctor. Initially, it may be every 3 to 6 months, then spread out to every year if the cancer appears to be under good control. Prostate cancer can be cured with radical prostatectomy. When discussing the likelihood of cure, keep in mind that the word cure is difficult to define and may be different with different types of cancer. With prostate cancer, because late recurrences can happen, cure is usually defined as no evidence of recurrent disease after 15 years of follow-up. Informing a man of his chance of cure after radical prostatectomy is more challenging than one may think, as it depends on a number of different factors, including your PSA value and the final report of the specimen removed at surgery, describing the stage, grade, and volume of cancer. Every man's situation is unique, and generalizations are difficult to make. Discuss the specifics of your personal situation with your doctor. Many resources are available to provide you with statistical information about the chance of cure in a variety of situations. Even when prostate cancer seems to have been completely removed or destroyed, there is always some risk that it may return later on. It is for this reason that careful follow-up monitoring is so important. Recurrence is less likely for tumors of lower stage and lower grade. If prostate cancer does recur, initial treatment options may include further watchful waiting, radiation therapy, and/or hormone therapy. In summary, radical retropubic prostatectomy involves the complete surgical removal of the prostate along with surrounding structures. It is performed with the goal of curing or at least helping to control prostate cancer. It is considered major surgery, and as such, a hospital stay is required. It is performed through an incision in the lower abdomen and a catheter or tube to drain urine is required for a short time after surgery. It is important to understand several important risks of this operation, and these are outlined in a separate presentation entitled Understanding the Risks of Radical Prostatectomy. Thank you for viewing this educational program.